So basically, this is another example of, I did not know Gayla or Leslie, and this was a situation where they contacted me. I can't remember what I was doing that they thought I would want to collaborate with them on this, but we got a grant together, and I didn't even know them, so, as I was telling you, feel very free to contact as long as you're contributing something to what the person you're contacting does. Okay, and so as I said, we tailor these, the RETI to what the new fellows are doing and what the returning fellows are doing. So as you know, Kate is doing something on clinical research staff, so I wanted to talk about a kind of mixed method study that we did with community, with research staff who did community-based drug use. And at the time I did the study, nobody bothered with studying the workers. People have been studying nurses, but nobody thought about studying stress or the experiences of research staff. So the aims of our grant were to identify and assess the moral stresses and practice dilemmas experienced by frontline researchers working on community-based drug use research. And then the second aim was to examine the relationships among moral distress, practice dilemmas, institutional climate, research commitment, and research mistrust among CRWs. So when we wrote the grant, this was a two-step process. Focus groups would help us identify what are the issues, because nobody knew of community drug research workers, and then to develop a survey to validate it, and then to look at relationships among the factors that we had identified from the qualitative research. So who was a frontline worker in our studies? They had to have direct face-to-face contact with participants. That could involve recruitment, screening, enrollment, intake, informed consent, interviews. They could lead or assist with harm reduction or focus groups or debriefing. So a preliminary study was 6 focus groups with community research workers on various projects in New York City, Hartford, and Philadelphia. And the inclusion criteria was that they had to have face-to-face contact, as I said before, but they had to live in the same community or share an experience like past addiction, or had received services from the agency that they worked for. Because we were interested in community-based research. These are people who go out into the field and recruit and conduct their research there. They might be in vans and things like that. Okay, so here were the themes that came up. The first theme was, obviously we did a contents analysis, and this is what we came up with. Role commitment. It's my responsibility to increase the community's trust in research. I mean, they were just such wonderful people. It was just, an honor to kind of meet with them. Research mistrust, though. Sometimes I feel the people I work for exploit research participants. Practice. So here were the practice moral dilemmas that they came up with. So, for example, one woman was saying, "I'm known as the HIV lady, so how can I keep confidentiality? Everybody knows me." Yeah. The other dilemmas where you'll see in our survey, people are always asking me for money. They're always asking me for help because I'm the one who works in the community, or they think I can help them with mental health. So it's, a lot of stressors. Then we asked about the research ethics climate. Did it provide, so they said their research ethics, they had training, but they weren't encouraged to talk about their own concerns. So it was very top-down kind of training. And they felt that they were constantly pressured to get the numbers. So when we asked them in the focus group, so what do? Do you, bring in people who aren't really qualified? Do you, how do you meet that pressure? And they said, oh no, we never do that. But it was so interesting. So it's so interesting. In the focus group, they always said they didn't do it. After, they all came over to me and said, yes, we do it. So what I thought was so interesting was they trusted me they didn't trust that we were taping them and that this was going to be the data that we were going to use. So very interesting to understand the ways they were looking at the confidentiality I had promised. Okay, and then emotional burnout. Sometimes I have to close out my emotions. So from this, we actually took their words. This is what I do if you're working on qualitative. If you really want to develop a new survey that people really haven't asked these questions before, I think also, as John was showing yesterday, you can take the words that people use, because those are the words that are going to resonate with your participants who are like them. So I had never heard of moral distress before. And I was really struggling, like, these people are upset about moral issues. What does that mean? And so I kept Googling words, moral, upset. And then I found, this huge moral distress literature that why should psychologists or anybody else know what nurses have been doing forever, and all these great studies and these great theories, so it also shows how we're so isolated from one another. Okay, so the definition from nursing of moral distress is feeling of anger, frustration, powerlessness, anxiety, and regret that arise when morally appropriate actions cannot be implemented due to institutional or other obstacles. Okay, and so that led us to kind of frame what our survey was going to be about under the auspices of what work-related experience and attitudes are associated with moral distress among community research workers. So we did exploratory scale development. We drew items from the focus group statements, and we also adapted scales that have been done for nurses and healthcare workers and some graduate students. We had a CAB that helped us refine, so we had a whole range of items, and then we had a CAB that was made up of the community research workers and their supervisors, not their personal supervisors, but they helped refine, and I'll tell you about one of the things they told us to do. Then all the items were scored on a 4-point Likert type scale, and then we did all the things you do to validate inter-item reliability, et cetera, et cetera. We really didn't have anything that could do concurrent validity because nobody had done this before, so we couldn't do that. Okay, so these were the 6 scales that we developed. It was a 110 item scale. So we had the work-related moral distress, we had the moral practice dilemmas, we had the organizational research ethics climate, whether they had staff support, how committed they were to research, and whether they had research mistrust. So our hypothesis was, based on our focus groups, that higher levels and also the nursing literature, higher levels of moral distress are associated with encounters with moral practice dilemmas and research mistrust. And then our second hypothesis was that lower levels of moral distress are associated with strong organizational research ethics climate, institutional staff support, and a commitment to research. Okay, so there were the risk factors and the protective factors. Okay, so recruitment and participants. So we looked at the NIH Research Portfolio Online, which is now called the Reporter, and the Clinical Trial Network, and we asked 188 investigators to please forward this announcement to current or recent community drug use research workers to be in this study. And I was just talking to Kate about it. Why would investigators do this? Well, we said we wanted to explore the challenges that community research workers are facing so that research could be enhanced and enhance the validity. And, well, I'll tell you this later. Okay. So our inclusion-exclusion criteria was that they had to have this kind of position within the past 12 months, obviously direct participant contact. We did a web-based anonymous survey, and participants received a $40 Amazon certificate. We ended up with 275 respondents, which was great. They were ethnically and geographically diverse. 23% had a personal history of drug use, and 67% lived in the community. Now, those of you who work with community workers know that many of them are hired because they've had the addiction problem themselves. But I had people come in, maybe in the early RETI, I don't remember, but talk about how they became addicted again because they were doing this research. And that's something really important to consider, especially in terms of the climate of the organization. What are you doing to make sure that that's not happening? Are you in touch all the time? So you'll see that's part of our recommendations. Okay, so I wanted to talk about what we told the community workers, right, in terms of what did the informed consent say. So community research, remember I said yesterday, I think it was yesterday, that you want to make people feel good. You want to make sure that the way you're identifying them is not stigmatizing in itself. So we say community research workers are on the front line of drug use-related research. However, little is known about the rewards and challenges they face when conducting this important work. The aim of this study is anonymous studies to gain an understanding of how CRWs view the achievements and challenges of their work, and then it went on and on. But just you see how I hopefully I was successful, but it was something I wanted to do. Okay, so here are some of the moral distress items, and these are the percentages of people that endorse those items as part of their experience. I know some participants have given false answers to get into a study. So we basically asked them what their challenges were. I did not believe some participants really understood the research they agreed to participate in. I believe that offering money made some participants ignore the risks of research. Again, all the things we talk about. But I guess in the real world, it doesn't always happen, right? We do an IRB protocol, but yet they're encountering this in the real world no matter how much we think that we've got a protocol that's protective. I could not provide participants with the service referrals they need. I could not correct a problem in how the research was conducted, and I believe the research screening criteria excluded people who should be in the study. That really bothered them, especially, as I said, people in the community always coming up to them. And sometimes they say, the PI has this criteria for injection drug use, and it doesn't work. They might take a different pill that day, and if I have to see if they did in the last 24 hours, that's not really somebody who injects drugs, because sometimes that drug is not available. So, they had really more insight than some of the PIs in terms of who the populations really were. So the other half of moral distress is burnout from the nursing literature. So here you can see they were emotionally drained at the end of the day. The job was stressful. They worried that it was hardening them emotionally. And these pretty high percentages for people on a job. They felt overburdened by the demands of their job, and they questioned the meaningfulness of it. Now, these are the moral practice dilemmas. The reason I have the total, and then we wanted to know whether or not the drug use study involved people with HIV, whether or not they'd be more stressed, but we actually really didn't find any difference. Okay, so look how many people endorse this. I won't go out to sell a study to drug users if I don't trust the investigator. I find it hard to sell a study to drug users when I do not believe the study will produce useful results. I exclude drug users from participating if I believe they are lying about which drugs they use. Interestingly, this is lower than you'd expect, right? But they have to stick to the protocol. I discourage drug users from participating in a study if I believe it will not be good for them. So as you will see, what's the point in doing this research if we're not reaching people? So as you'll see, the way the article was written in the end of this is, what does this mean to PIs? Because when I went around presenting this, the only thing PIs were really interested in was whether or not this was jeopardizing scientific validity, which this obviously it was. Okay, so what were some other boundary issues for moral practice dilemmas? Even when it's not part of my job, I counsel participants about their drug problems. once again, we have to think about this in terms of their moral distress as well as the validity of studies that are being conducted with these people who are feeling they have to give something more than the research. The questions I am told to ask unintentionally give away the drug inclusion criteria. If you don't require feedback from your community workers, you're not going to know that. I use my own money to buy coffee or other small goods to keep drug users interested in participating. I find it difficult to protect participant confidentiality when people in my community know what type of study I'm working on, right? And remember, I took all of these from our focus groups. And so, now this was very interesting. So you saw those questions. They could be upsetting. Well, not upsetting, but revealing, right? So the CAB had recommended that this is how I introduce the moral dilemmas questions. So this is how we introduce those. The statements below are based on opinions expressed in focus groups by CRWs involved in drug use and related research studies. For each statement, think about your experiences as a CRW working on studies involving drug use. Check the box that indicate. But there are no right or wrong answers. We're just interested in your experiences and your opinions. So this was something I actually, introduced because the CAB recommended that. And obviously it worked because we got high percentages. Okay, what's this? Okay, so research commitment was another scale that we did. There were 6 items. Here are just some examples. I believe the results of study will be used to help the community. It's my responsibility to increase community trust. You saw that was a quote from before. I see myself as a bridge between the community and research. I feel responsible for educating the community about the importance of participating in research. And then we asked about research mistrust. So half of the participants endorsed 2 items or more. So here are people working in research. Some people in the community distrust me because I'm a research worker. Most investigators don't care about participants. They just want to get the study done. Drug users in poor communities are paid less for being in a study than middle-class drug users. Drug use-related research that is conducted in poor communities will mostly benefit middle class, and research exploits drug users who are desperate for help. So at least 25% agreed with that statement. Okay, so now I wanted to ask about the research ethics climate, right? Because part of the hypotheses were that. You can see they all thought that their institutions had adequate policies with respect to privacy, confidentiality, et cetera, but here, the community never got the results. Although 68% is pretty high, I think, in terms of getting results back to a community. So, and here, this is amazing. 81% said they provided training in research ethics for the CRWs. Obviously, something was lacking from that training, but not in terms of them being unethical, but in terms of addressing the challenges they would be facing. They also thought they got a lot of support, but they felt that the expectations were not realistic. Only 62% got counseling when they experienced trauma from their research organization based on the research, and only half did not require CRWs to take on too many roles. Okay, so remember, we had hypotheses. So as you can see, remember we hypothesized that the more moral practice dilemmas you endorse, the higher your moral distress would be, and that came out highly significant. We also predicted that research mistrust would increase moral distress. That was really high. Here we predicted that a supportive institutional ethics as well as research climate and scientific commitment would reduce stress. And I just thought this was interesting. We didn't have a hypothesis about it, but research mistrust was significantly related to having the moral practice dilemmas, whereas institutional support was not, reduced those dilemmas. Okay, so what are the implications? Again, and this is also like impact, right? When you're asked on a grant, you have to say what your impact is, which is very hard sometimes for us. So the majority of CRW's work settings have a supported organizational climate and procedures to ensure research integrity. So another thing, when you're writing an ethics paper, for the most part, you don't want to come out as, I had to learn this because, I was real angry and I was telling when I first started out writing ethics papers, and then people would say, wait a minute, nobody's going to listen to you because all you're doing is insulting them. So, try to frame it in terms of, positive and negative here. Okay. The majority of CRWs are highly committed to their work and see themselves an important bridge between the community and research. However, 75% endorse at least one item viewing research as exploitative. Over half are faced with difficult personal and professional moral practice dilemmas. In terms of moral distress, CRWs see themselves as moral agents attempting to achieve an overarching moral good. This was from a nursing quote. They feel a moral responsibility to address social injustices experienced by vulnerable participants, and moral distress arises when the researchers cannot actualize these values via their work. Approximately half of CRWs experience some level of moral distress, and so the protective factors were what we had hypothesized. The risk factors were perceptions of research as exploitative and moral practice dilemmas. So moral practice dilemmas arise in instances in which adhering to either scientific integrity or social justice requires abandoning the other ideal. And remember a couple of days ago, I talked about Robert Beach talking about the scientist-citizen dilemma, that sometimes we want to do good science, and then we feel as a human being and a citizen, maybe we're not helping somebody or we're harming them even though it fits protocols. So they're experiencing the same thing. They want to do good research, but they're also seeing its impact or that it's not enough on the people that they care about. So research mistrust and research responsibility are refactors. In addition, I already said that. Okay, so here I'm trying to get PIs, when I gave this talk, to be thinking about this. So what are the risks to study generalizability? So poor ecological or external validity of screening protocols, for example, happen when CRWs exclude, representative, or the PI excludes representative populations. Or when a CRW may alert a drug user to inclusion criteria. Or they include subjects who are misrepresenting their drug use because they think they need the treatment. Or there's an erratic application of the screening criteria. What are the risks to scientific validity? Research designs with little perceived participant or community benefit are threats to internal validity if the CRW feels responsible to counsel or provide referrals to participants, and threats to generalizability from lowered recruitment levels when CRWs do not believe the participant will benefit from the study. What are the threats to research integrity? Inattention to dual role burdens perceived by CRWs and lack of CRW's feedback about their experiences lead to CRW exploitation by the community, to burnout, and to uncorrected problems with research implementation. So, in case they didn't get it, these are the implications for principal investigators. CRWs have valuable expertise and research challenges in the field that can strengthen scientific validity and integrity. Their jobs are vulnerable to moral practice dilemmas and moral distress, and their efforts to overcome obstacles to actualizing their perceived moral responsibilities threatens the scientific validity and integrity of studies. So what should you do? You really, what should principal investigators do? Include CRWs in the design of recruitment, inclusion, and exclusion criteria and other community relevant research procedures. Set aside regular team sessions for debriefing and feedback. Obtain first-hand knowledge of the research community to enhance scientific validity and research integrity. Like I said yesterday, a lot of the community members thought that the PI never saw what an addict on the street looked like. that it was only the community workers that ever saw this person. And that's that. So we can start with discussions about this particular study, and then going around and talking about your staff, that study you're going to do or studies you have done, and what do you start needing to be thinking about.